Good evening. I'm Scott Succo, your Executive Director of the Liver Coalition of San Diego, and welcome to another series, an episode in our series of our Liver Q&R webinars 2021. We've got a great topic tonight with a member of our Medical Advisory Council, and we'll learn about that in just a bit. I want to start by letting folks know that tonight's webinar will be recorded, and also this webinar is intended for educational purposes, and you should not interpret it as individual medical advice if you're a patient or caregiver. Also, throughout the evening, the webinar, you are invited to ask questions. So you'll see a chat box or a question box. Put your question in there, and the moderator will field those and make sure that they get answered either as they come up, or she'll group them together and answer them when it's most appropriate for the presentation. At this time, I'd like to thank our sponsors. The webinar could not be possible without the support of our generous sponsors and partners. First, I want to welcome Eric with Gilead. And Eric, thank you so much for being here. Would you like to say a few words?
Thank you so much, Scott. I just wanted to say thank you so much for the Liver Coalition of San Diego for having us. We are happily able to sponsor, as you may know. Gilead is fully committed to the liver and all liver diseases, with hepatitis B in our Vemlidy franchise, with our hepatitis C in our Epiclusa or sofosbuvir franchise, and I look forward to seeing the future in 2030 where we're able to eradicate this virus of hepatitis C. So thank you so much. Thank you for all you guys do, and I'll turn it back over to Scott. Thank you.
Great, thank you, Eric. Our next sponsor is ASI, and ASI, Bobby's with us, but he's in the green room right now, but they've got a great video that they put together. So let's watch that video now. Great, thank you, ASI. And also, we want to thank our partners from AbbVie, and Elena is in our with us always. And so a nice video from AbbVie, and we'll watch it now. Great. Thank you to our friends from AbbVie. And also, you'll notice on the PowerPoint picture below, our friends from Dynavax are also a sponsor, and we really appreciate the great work that they're doing in the hepatitis B community as well. A little bit about the Liver Coalition of San Diego. We, although we are a newly formed organization, we have our volunteers have been active for 25 years in San Diego. When the American Liver Foundation had to close their offices, they've organized and said that there was a gap that they felt they could fill, and they continue to carry the torch and offer these essential programs and build off past successes. And we're just doing it under a new name, the Liver Coalition of San Diego. So we do have a mission that's consistent with our work. It's to save lives by improving liver health. and preventing liver disease through the community-based education, linkages to care, advocacy, and research programs. So very excited to be here continuing the good work, but just under a different name. I want to introduce tonight's moderator, Shirley Sunuda. She's a pharmacist, and she's with the UCSD Skaggs School of Pharmacy and Pharmaceutical Studies. She's also the co-chair of our Associate Medical Advisory Committee. Shirley will introduce our speaker and then moderate from here on forward. So welcome, Shirley.
Thank you, Scott. Happy to be here. And it's my pleasure to introduce Dr. Tarek Hassanein. He is the director of the Southern California Liver Centers and the director of Southern California Research Center here in San Diego. And he's going to be sharing with us his expertise in alcohol use disorder and liver disease. Dr. Hassanein?
Yes, Shirley, Scott, it is always a pleasure to see you guys and work with you. And I have to comment about the years of commitment that you had in the discipline of liver disease. So I know Shirley, we were catching up. I know her since she was a young pharmacist at UCSD, participating in the liver clinic and the liver transplant program when I was there. And she's still going strong in research and in education and training, and very active in the community of liver disease. And of course, Scott and the efforts Scott has done for the American Liver Foundation. And when the American Liver Foundation during the COVID decreased their activities in San Diego, the Liver Coalition and the work that Scott did and the rest of the team was really impressive to get to keep our patients informed, webinars, programs, meetings, and despite all the issues of COVID. And I thank you for inviting me to talk about the topic of today. And I will be talking about the issue of alcohol. The alcohol alcohol has always been a cause of chronic liver disease, and not only chronic liver disease, but a number of disorders that we have been living with for thousands of years. And to a certain extent, over the last year and during the COVID restrictions, the alcohol use disorder became a topic that we read about every day in newspapers, and we watch it on TV because there's a significant increase in the number of individuals who used alcohol or even overused the alcohol to the point that alcohol use disorder, and we're going to talk about that new word, alcohol use disorder, means and how it impacts the liver. You know, I have spent the last 30 years of my career working on alcohol and the liver, and today I'm going to try to give you a quick review of what's happening in that field with the alcohol use disorders. We know that alcohol, and all of us uses alcohol to different degrees, to different amounts. It's a liquid that we drink and make us feel good. And it makes us feel good because it has metabolic effects on our body and on our chemistry. Very quickly, it gets absorbed from the gastrointestinal tract. And actually, if you say, I don't drink, but I don't eat, but I drink alcohol, I'm saving calories, I want to remind you that 1 gram of alcohol produces almost 7 kilocalories. So it is not just a drink without calories. It produces and gives the body a good amount of calories. It gets eliminated through our kidneys and our lungs. So when we breathe after drinking, you can smell the alcohol in our breath, because that's how we get rid of the metabolites of the alcohol. 90% of this alcohol that we drink will be absorbed through the gut and goes to the liver. And the liver is the organ that handles the alcohol. So if my liver is a very healthy liver, it metabolizes the alcohol fast. If my liver has some issues, it might take some time to metabolize and break down the alcohol. And to a certain extent, the liver and the liver cells are highly affected by any degree of alcohol intake. Now, when we go into biochemistry of the liver, there's certain effects, particularly on the oxidation of fat, oxidation of protein and carbohydrates, and you can see it decreases the oxidation of fat almost by 80%. It decreases the oxidation of protein, which means a breakdown of protein by 40% and carbohydrates by 100%. Now, what is the issue of alcohol and why we get side effects from the alcohol? It's because when the liver breaks it down, we call it metabolites, and there's few of these metabolites are toxic. And you can imagine that's why we hear about liver alcohol and liver disease. That's not a problem in the US, it's a problem around the world. And you can see here, actually, we don't drink in the US as much as some Northern European countries and Australians drink. And you can see that the consumption of alcohol is quite prevalent all over the world. If you look at the places where you can get data, it correlates to the patients and the numbers of patients with advanced liver disease and advanced cirrhosis. So to a certain extent, we know alcohol induces cirrhosis since thousands of years, and there's good correlation between how much we drink and how much we develop cirrhosis. Although not everyone who drinks will develop cirrhosis, but they might develop some liver problems, but not to the extent of developing full-blown cirrhosis. And then there's a group of human beings who are privileged by certain genetics that even if they drink and they get all the side effects of abusing or overusing alcohol, they still don't get a liver problem. So we always see in our patients, in our clinics, patients who are heavy drinkers but never developed a liver problem. When you talk about alcohol and the impact on the liver, there's an estimate over 3 million deaths every year from alcohol. And you can imagine there's 140 million disability adjusted life years related to the use of alcohol. So alcohol, as I mentioned, doesn't only affect the liver, it affects a lot of organs. And there's over 200 diseases and types of injuries related to the use of alcohol. But most mortality and death is attributed to cardiovascular disease, injuries, and GI diseases, mainly cirrhosis. So to a certain extent, alcohol affects the heart, affects the mentation, affects the concentration, and so on. And it increases the chances of cancer. So to a certain extent, even pregnant women, when they overdrink, they can have their fetuses affected by the alcohol in what we call a fetal alcohol syndrome. So the question that I always get, and you know, in the public, in the clinic, in any meeting, is always, what do you mean by drinking too much? So the quantification of alcohol consumption is not easy. And so to a certain extent, someone can mention, oh, I always have a night drink, or I always have a beer or a couple of beer, or you know, over the weekend during the game, I go through a pack of beer. So to a certain extent, the quantification of how much alcohol a person uses is always a bit challenging, because sometimes you use less, sometimes you use more. But when someone comes to our clinic and we are trying to figure out how much they drink, we always ask, you know, about the number of drinks, what's the type of the drinks, and the type of alcohol they are consuming. And on top of this, the time and the frequency by which they drink. So to a certain extent, the WHO defined one standard drink that it contains 10 grams of alcohol. So, and we know the gram can produce certain amount of calories, and we know the grams can lead to a certain injury to the liver. And then when all of us go out and have a drink here and there, we don't call this harmful drinking, because there is a very specific definition for drinking that is harmful, where the alcohol use is causing damage to either physically or mentally. And then we have heavy episodic drinking, where someone would consume more than 60 grams of alcohol. And we're going to get into what's a gram in relation to a drink. Okay, so if someone drinks 60 grams of alcohol in one occasion, we medically call this, and socially would call this, heavy drinking. And if they are doing it every now and then, it's heavy episodic drinking. And then we know the binge drinking, which is the consumption within 2 hours of 4 or more drinks for women and 5 or more drinks for men. So if someone sits for a couple of hours, consume 5 drinks during these 2 hours, that's what defines binge drinking. So here's the famous picture where when you look at a can of beer, which has a 5% alcohol, and it's 12 ounce of regular beer, that's constitute almost 10 grams of alcohol, 10 grams of alcohol. Now, when you get to a glass of beer, 7% alcohol concentration, 8 to 9 ounces. Now we are talking about, this is close to 14 grams of alcohol. But roughly in my clinic, and most doctors would say a can of beer or a glass of beer versus a glass of wine or a shot of whiskey or liquor, all this comes down to around 10 grams of alcohol in each of these drinks. Knowing, of course, that beer and different drinks, you know, the beer might have 5% alcohol, the malt liquor 7%, the wine 12% alcohol concentration, and the liquor is 40% alcohol. But roughly, if I'm drinking 2 cans of beer, then I drank roughly 20 grams of alcohol. So if I sit and I finish 6 cans of beer, now I got to the 60 grams, which is what we have called a little bit a harmful or heavy episodic drinking. Okay, so here's another way of looking at it. Depending on what you consume, you can easily be consuming a pint of lager, 20 grams, that's 20 grams of alcohol already. So to a certain extent, when someone is drinking We always advise them not to binge drink. We always advise them to minimize the amount of drinking. We always advise them to enjoy it, savor it, sip it, and make sure that you space the drinking over a longer period of time. These are things that helps anyone to avoid the repercussions of alcohol on the liver. What happens if I go on a weekend and I drink a little bit more than usual, and I start with a very normal liver? That weekend, if you come the next day to me and I do an ultrasound or a fibroscan, I can see that your liver already getting some fat deposition. And then, you stop drinking and the fat can be mobilized out of the liver, and say you repeat this in another 4 weeks. By 4 weeks, the effect of that day of binging is gone and your liver looks better. Then you go through another episode and your liver gets fatty. And over time, people develop what we call alcoholic hepatitis, or they develop more and more scarring in their liver and they reach cirrhosis. So to a certain extent, not everyone goes through these stages, but people can jump one stage to the next, or people can go from one stage to the next in 1 year or 5 years or 10 years or even 20 years. So every individual is different. Now, when we do a liver biopsy and we look at the liver, and this looks like a liver that has a lot of white spots, and that's what we call the fat. And then it has a lot of big cells, like the arrow there is showing on a big cell. That's what we call ballooning, which means that the cell is in the process of dying. And then when the cells die, our body goes in to clean up. We call them the vacuum cleaner cells, lymphocytes, special cells. They come and they clean up, and then they start telling the liver to heal by scarring. And the scarring is the blue stripes that you see on this tissue. So you see the white spots, that's the fat. The arrow showing a very big cell, that's what we call ballooning and fibrosis. And to a certain extent, here on the second panel, we go from normal liver to steatosis, which means a lot of fat, to fibrosis, then to cirrhosis. And we know anyone who reaches cirrhosis has an average of 4% every year of developing liver cancer. Now, let's say I stop drinking halfway somewhere there. Your liver can recover because we know that the liver remodels and very effective in remodeling. Now, on the other hand, if I'm drinking and then I get hepatitis C or I gain a lot of weight, now I'm talking about adding more injury to my liver. And instead of moving from one level to the next in 5-10 years, I can actually move from one level to the next in 2 to 5 years faster. So very important lifestyle and other comorbidities and factors needs to be adjusted and managed in patients who drink alcohol. Example, diabetes, controlling the weight. If they have a viral infection, get rid of the hepatitis C, the hepatitis B, avoid smoking, and so on. So in gross, when I remove a liver, the first panel here on the left is a healthy liver. The alcohol give it what we call fatty liver that looks a little bit yellowish because it has a lot of fat. And then 30%, 10 to 30% of patients can develop that very dangerous condition that is called alcoholic hepatitis. But a lot of people might not develop it. We're talking about 60 to 70% might not develop it. And they move all the way to cirrhosis over 10, 15, 20 years. And patients with cirrhosis, as we always said, can develop liver cancer. Now, I love this slide. It's an old slide, you know, it's from the 90s, but it details how a molecule of alcohol goes in the body, in the liver cell actually, and the liver cell's biochemistry starts breaking it down. When you look at the liver cell, every part of the cell is overreacting. And when it overreacts, it produces the metabolites, the acetaldehyde, which is well known to be toxic, particularly to what we say mitochondria. And the mitochondria of the cell is what we call the power of the cell. Our body cells need the mitochondria to function. So if my liver cells get a lot of this metabolite of the alcohol, that leads to my mitochondria overworking and then paralyzing and stop working, that's when the patient starts getting into what we call acute alcoholic hepatitis and failure. So we clearly know that the alcohol gets metabolized very fast by certain enzymes in the liver. There's 3 different pathways inside the liver to metabolize the alcohol, and these pathways, if one of them is sluggish, the other one overrides, and the third one takes over. So sooner or later, your alcohol that reaches the liver will be metabolized. It might take time, but ultimately it will break down. Recently, people don't like to use words like, oh, this person is alcoholic. That's stigmatization. So to a certain extent, the medical field started changing these terms. So if someone drinks a little bit more, and we're going to talk about more definitions of that, we call it alcohol use disorder, AUD. So we don't call people alcoholics. We don't call people, you know, they are alcohol addicts. No, we lump all these issues under a term called alcohol use disorder. Now, if they have a liver disease, we call it alcohol-related liver disease. If they have liver cirrhosis from alcohol, we call it alcohol-related cirrhosis. But if they didn't reach cirrhosis yet, but the liver is too fatty, and I have to tell you, I have seen the liver size, the liver's length is around 15 centimeter. It's like a football. I have patients that the liver reached 30 centimeters after drinking. And they come with a right upper quadrant pain. And when you do an ultrasound or a fibroscan, you see a humongous liver. And that humongous liver is because of what we call steatosis or steatohepatitis, which is too much fat from the alcohol inside the liver. Then if the liver has scarring, we call it alcohol fibrosis due to alcohol liver disease. Or if the patient gets the worst condition, which we call acute alcoholic hepatitis, which is the liver is on fire. I call it the liver is burning. The liver is on fire. So the psychiatrists, they got together in the DSM-V, and they defined alcohol use disorder as a problematic pattern of alcohol use leading to clinically significant impairment. Okay, and so to a certain extent, the WHO still uses the terms hazardous or harmful alcohol use or alcohol dependence. Some other people can use risky drinking, but the term alcohol use disorder is now clearly defined by the DSM-V criteria, which we use when we define these conditions, and it is replacing alcohol abuse or alcohol dependence or risky drinking. So that's that definition of alcohol use disorder, a problematic pattern of alcohol use leading to clinically significant impairment or disturbances. Now, how they reach that decision, they ask questions, and depending on the questions, and if you answer yes to 2 of these questions, then that person have alcohol use disorder, and it has different severity, like, you know, how much you drink, how often you drink, how much, if you desire to drink, do you have the craving, if recurrent alcohol use resulted in failure to do your job or take care of your family, or you get in an accident, is recurrent alcohol use is physically hazardous, and so on. So these are very well-structured questions that went through a lot of trials to come down to be on this table here. And if someone has 2 or 3 of these criteria, they have mild alcohol use disorder. If they have 4 to 5, we call it moderate use alcohol use disorder. And if it's severe, we call it, if it is more than 6 or more, we call it severe alcohol use disorder. When you come to my clinic, or if you go to a liver clinic that deals with alcohol, still we have been using the audit. And again, it's the simple questions that we give our patients and they answer, and we score it. And if they score above 8, that's what we call hazardous alcohol use disorder. So to a certain extent, we are trying to have objective measures to define the alcohol use disorders, accordingly define how aggressive of intervention we need to do. So it's very important over our lifetime when we go to our doctors or interacting with our families that early recognition helps. Don't wait till people get deep into the syndrome before we start helping them. We want to help them much earlier. So early recognition and intervention is very required, and it's required by the primary doctor, by family members, by friends, and so on. And it's very simple. When I get a patient who comes in and say, I have a liver problem, and I'm asking why, well, you know, how he got into liver problems, some of my patients will say, I drank, and, you know, sometimes I overdrink, but I stop here and there, and I need to know how bad is my liver. And as a doctor, we do blood tests and we do some radiology. And now we have this new thing, that transient elastography, which is like the fibroscans and similar equipments, very simple, like an ultrasound, that tells me if someone has major problems or not, because these transient elastography easily detect in 5 minutes how much fat is in the liver, how much scar in the liver, and we can guide our patients to the extent of their disease. And I have a number of patients who like their alcohol, they don't want to leave their alcohol, but, you know, we help them through the process by optimizing their physical and nutrition condition and minimize the effect of the alcohol on their liver using some of these blood markers and elastography. So screening is important, and getting to someone and defining or saying, oh, I need help, or someone guide you to ask for help is very important. And why this is very important here? Because we are dealing with a very nice organ, the liver, which has a capacity to regenerate and come back. Accordingly, alcohol abstinence really can get the person's liver back almost totally to normal. So when you look at these 2 curves, there's a blue line. These are individuals who had significant liver issues, but still the liver is compensated and working. And once they stop drinking, the liver recovers totally. Versus, oh, you know, I have advanced cirrhosis now from alcohol. But I stopped drinking, and guess what? That's the curve on the right, the figure on the right side here, and the blue color, the blue line shows that almost you regain 60% of your liver functions versus if someone continued to drink and continued to lose the liver all the way to losing over 70% of the liver, and now they might need a new liver. Are there any drugs that can help the patient not to go back? Yes, there's a number of drugs, and we sometimes use them with our patients. And some patients come and say, yeah, help me out and we will stop drinking, abstinence. And some would say, I tried, I cut down, but I cannot stop it. Can I have a medicine? And we have a number of medicines that can help our patients to stay off alcohol. Now, all these issues with the alcohol, we can recover these patients, the majority of the patients. The one entity that really we are specialized in and really is dangerous is what we call acute alcoholic hepatitis. And literally, the alcohol went to the liver cells metabolize the alcohol, produce these metabolites, and these metabolites, it starts burning the liver, paralyzing the mitochondria, making the cells, although they are there, they are not working, inviting all the inflammatory response to come to the liver, and that's what we call acute alcoholic hepatitis. I call it a liver on fire. And it is a problem. There's almost 60 to 90,000 patients admitted every year. Here in our hospital at Sharp in Coronado, we are a center of managing these patients. And during the COVID time, we got bombarded by patients from the over drinking at home. So the problem with this disease that half the patients coming in will die during that hospitalization. So you're talking about within 90 days, almost half of these patients will die. The only way to save them by giving them a new liver, a liver transplant, but liver transplant requires, and the insurance requires, and the doctors require 6 months of sobriety. So a lot of these patients are not candidates for transplant. So to a certain extent, what do we do with these patients and how we can avoid getting there? We don't want to end with acute alcoholic hepatitis. And you can see here, here's the patients in red. These are the individuals who came with severe acute alcoholic hepatitis, and their survival in 90 days is almost 50%. Now, if they had a little mild hepatitis and they stop drinking, they recover totally. If they have a moderate degree of alcoholic hepatitis, they recover, in 80% of the time they recover. The problem when they come in with severe alcoholic hepatitis. So what makes it severe? We actually, over the years, different centers around the world developed models to predict the severity of the acute alcoholic hepatitis and the survival of the patients. And to a certain extent, when you go to one of the liver centers, they, on day one, they look at these models and they can talk about the chances of the patients making it through that hospitalization or not. The bottom line is we don't want to be there. How we treat this is challenging, and I can tell you up till today we don't have a treatment. So imagine, you cannot believe that we have such a common problem around the world and we don't have a good treatment. However, the way we approach it by abstinence. Patient comes to the hospital, they will not drink alcohol in the hospital. When they come to the hospital, I make sure that their nutrition is optimized, because a lot of our patients who come in with acute alcoholic hepatitis have neglected eating correctly during their time when they were drinking. And improving the nutrition improves the outcome. And then every patient who comes, we try to screen them for liver transplantation. There is new protocols that some of the patients can be candidates for transplant. Then we have some treatments, corticosteroids, pentoxifylline. We have what we call liver support by extracorporeal albumin dialysis. And we have a number of protocols using new molecules, try to minimize the inflammation in the liver and try to stimulate mitochondria to come back. Here's the most impressive study that was published in New England Journal of Medicine that talked about what our main line of treatment, which is prednisone. And when you look at the 90-day mortality of patient on prednisone or no prednisone, you can see there's no difference. So this is a group with prednisone. Here's a second group, no prednisone, 30% mortality. Pentoxifylline is out of the picture, has no effect on this disease. The 1-year mortality is almost 55%. So these are diseases or a condition that is really can cause mortality in 50% of the patients. This is a big study that happened in England that showed that prednisone that we used to depend on really doesn't make a big difference except in a very small number of patients. And accordingly, we know prednisone and corticosteroids has a lot of side effects, particularly in liver patients, and using it should be done by experts in the field and not showing up in the emergency room, your eyes are yellow, you are feeling okay, but your liver is not doing well, make sure you don't drink anymore, take that script, take your prednisone. That's not how we use prednisone, because as we said, prednisone can help few patients, but doesn't help the majority of the patients. What about the general measures? We talked about abstinence. We talked about, giving vitamin supplements to avoid confusions. And then we talked about how we optimize the liver or the patients and minimize liver injury to help the liver to kick back in and regenerate. We found out very clearly that patients with heavy alcohol consumption are very deficient on micronutrients, particularly certain vitamins. And that's what you tend to get when you come into the hospital. We put a bag of fluid that has a lot of vitamins. They used to call it banana bag. And that's to supplement the patient with the proper vitamins. A new theory came out in the last decade talking about, the alcohol drinking has an effect on the bacteria in our gut, and bad bacteria in our gut. The good bacteria goes away, the bad bacteria stays, producing toxins that gets absorbed, that goes to the liver, and the liver already not happy with all the alcohol in it. Now I am overworking the liver, putting extra burden on the liver, to the extent that some investigators relate that if we fix the gut bacteria, the microbiota, we might minimize liver injury. It's a theory, and a lot of us are working on it. And to a certain extent, there's a lot of ways of how to modulate the gut bacteria with certain types of probiotics, prebiotics, and so on, or with even targeted approaches, giving certain types of bacteria or inhibiting other types of bacteria. An area of research, it's not yet mature enough to change our management of acute alcoholic hepatitis outside the clinical trials. Okay, so we know that the alcohol makes the body breaks down the proteins, so patients start losing their muscles, their protein. They need protein to compensate. So if they cannot eat and they don't have the appetite to eat, we try to push feeding. We talk about supplementing them with supplements. If they cannot keep up or they have issues with confusion, we put NG tubes and we feed them. Feeding is very important. Actually, when the patient comes, we overfeed them because their body is missing the nutrients and missing the calories that needs to come from certain food components. What about transplant? This is a busy slide, but look at the bottom reddish pinkish curve. You can see here over the years, the number of patients transplanted for alcoholic liver disease has been steadily increasing to the extent that it's almost 35 to 40% of all transplants are related to alcohol-induced liver cirrhosis. Now with the advancement in hepatitis B and C therapy, we have much less patients that we are transplanting with Hep C or Hep B. But when you look here, should I transplant the patient early, when they are early in their liver disease, cirrhosis, or late? The difference happens when they are in advanced liver disease. There's no difference in between transplant or managing them without transplant in patients with child A, which is early cirrhosis, or child B. The difference is very prominent in patients with child C. They need the transplant, and that's a group that we try to work with them to get the 6-month sobriety that the transplant center is requiring to give them a transplant. Other potential targeted therapies, we have in our center a number of clinical trials addressing the different mechanisms by which the alcohol injury the liver. And that's a different topic for research, and we offer it to our patients who fail to respond to standard therapy. What about this ECAD, extracorporeal albumin dialysis? It was approved in as Mars. That machine was approved for liver failure from drug toxicities, and because it has the effect of detoxifying the blood from the main toxins that accumulate in patients with acute alcoholic hepatitis, we have a protocol that we put patients on it, and now we have even advancement. We have a new study starting in our center about a new machine working with the same concepts of albumin type of dialysis. We know that the albumin can remove more of the toxins that accumulates in the blood from liver failure than regular dialysis. And in 2002, we had the first study showing significant improvement in survival, 30-day survival of alcoholic hepatitis patients using the ECAD, using the Mars device versus control. And that was the beginning of looking at this type of therapy in these patients. Now, more data have shown that if on the left here, on panel A, if you have acute liver failure, acute alcoholic hepatitis, and you got a treatment with ECAD and then a transplant, these patients do very well than just giving them ECAD. So the way we look at extracorporeal albumin dialysis is to bridge the patient, to buy them the time, the 6 months that during which they are sober to be candidates for transplant. But quite often we have seen that patients, when they get through these 6 months, their liver might recover to the point that they might not need a liver transplant. But the goal is bridging to transplant. And that's how we do it. When the patient comes with acute alcoholic hepatitis, we stop the alcohol, abstinence, we give them the nutrition, the vitamins, try the prednisolone, pentexophyline is out. If they get better, then we stop there and continue supporting them. If not, then we get them on the ECAD. And some of our patients might not respond, but the patients who respond and we can bridge them to liver transplant, that would be our goal. So let me stop here and just give you a quick summary. Drinking alcohol, we cannot stop drinking alcohol. But if you talk to a physician in the field of liver disease and say, what is safe in drinking alcohol, they would say 0 alcohol is the safest. But if it is not 0, keep your alcohol drinks less than 10 grams a day or less than 14 grams a day. And if you have an underlying liver condition, you might make it even lesser than this in a week. So there's no magic number. Less is better if you're going to be drinking alcohol. And if you start feeling that you're drinking more than usual, then try to figure out how to reach someone so we can tune up the liver. They help you to tune up the liver, do what we call HALO, health and liver optimization, and avoid getting into problems. Thank you very much for attending tonight's talk, and we have close to 10 minutes for any questions that I can answer. Thank you.
Thank you, Dr. Hassanein. We don't have any questions yet from the audience, but I thought I could ask you a question.
Sure.
How successful are patients after transplant who get transplanted for alcoholic, hepatitis or cirrhosis? And do very many patients return to drinking? And what is the success rate of transplant, for alcoholic liver disease?
So transplant for alcoholic liver disease is very successful, very effective, the best outcome. Then the second question is, if I drank that much to the extent that I got cirrhosis and transplant, after transplant, am I going to go back to drinking? That explains why some centers demand 6 months of sobriety, documented sobriety, attending AA, attending different programs to make sure that as a transplant candidate, I will not go back to drinking. So what about the data about drinking after liver transplant? Over 50% of individuals drink. The majority, they will have a drink here and there, but the extent of going back to drinking heavily after transplant depends on how long you have been sober before transplant. However, in all our experiences, we have our patients who couldn't stop drinking, and we always advise them to come back, and we can try to help them to get to the point of minimizing or stopping drinking.
And what about the role of some of the drugs that are used for, alcohol cravings, like acamprosate and naltrexone and baclofen? Do you see a role for those medications in your practice, and either, before patients get to transplant or even after transplant?
Yes, definitely. But I want to make it very clear that it's a disease that a pill from any of these good medications is not enough. It's a disease that requires a team approach from family support, friends, and the community, from the doctor who handling the liver, from the psychologist or the psychiatrist, from our rehab people. So the individual who had issues with alcohol use disorder should always keep that group around him, because they help him all the time. The worst thing is to stay alone, thinking that one pill might do the trick. We need to actually give the detailed, comprehensive support for that individual to be very successful in avoiding getting back to the hazardous or harmful type of drinking.
Great. Thank you so much, Dr. Hassanein, for that very great summary of alcoholic liver disease. And I don't believe there are any further questions. So I'd like to, again, thank you for your time and your expertise, and also thank our sponsors for this, for sponsoring this webinar.
Thank you. Thank you very much.